And it was funny. I was planning out 2026 a little bit and so excited about doing more teaching and the FSM rehab course, and it's almost done. And with that comes cutting back on my practice. And so I was having the conversation as my lease is up in 2 months. Do I just stop practicing?
Thank you for subscribing to the Frequency Specific Microcurrent Podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carol and Kim Pittis.
Hi.
Hi.
Now we're on. How are you?
Take two. It's all right. We can edit whatever we want out. It's our podcast. I think we should do like a bloopers reel. Oh,
Yeah, for sure.
that looks like laminated.
No,
Did I?
it's the advanced schedule.
I know, but it looked shiny. So I thought it was maybe laminated.
It's only shiny because we have the shades up because it's sunny.
Oh, that's nice.
It's sunny and 63 degrees, but for Portland, that's good.
I'm going to say it's warmer there than it is here in California. And
Wow.
a little chilly.
We're just lucky then.
We're lucky.
Yeah.
I am so excited about the advanced schedule. And I was texting with my co-speaker on Sunday, and I had highlighted in yellow our talk. And I said, I hope this still works. And he says, yep, it sure does.
Good.
So I'm so excited.
30 to 3 o'clock. I put you guys right after lunch. The only way I could find room for everybody was to make lunch an hour. We usually have an hour and a half, so they do yoga or Tai Chi. So nope. Now it takes us a half hour to eat and a half hour to visit.
Yeah.
Then we have breaks to visit.
And it's not like they have to go. You do such a great job of taking care of everybody. So it's not like you have to drive miles to get food. It's all right there. So
oh yeah,
grab a plate, get it down, and then stretch your legs.
We start with Juliana Mortensen, and then Kasia from Poland has 2 case reports, one on an ovarian cyst surgery that got canceled because she got rid of the ovarian cyst. Duh. And then thyroid gland that was hyper probably, and TSH. And so she has pre and post treatment data. Then there's who's applying statistics in N of 1 case studies.
Yeah.
So that's a statistics guy. And then we end Thursday with John Sharkey between 4:30 and 6. And that should keep everybody awake at the end of the day. And then, hi, Leaf. And then David Musnick is in the morning on Thursday. You're in the morning on Friday. Then Patrick Wood, the midbrain and the dopamine pathways. Christy Hughes on integrating FSM into an integrative team. So if you're in a multidisciplinary practice or if you're doing integrative medicine, so there's that. Then Eduardo is doing more magical and wonderful things that we should know about the Dura. And then Guillaume is coming from France for the first time in 10, 12 years. And it's treating complex cases in 30-minute sessions.
Yeah. So
a lot of the PTs will have problems thinking about, I only have a 30-minute session. What can I do? And in France, that's all I have are 30-minute sessions. So Guillaume was talking about that. And then John Reske, discovering, understanding, and treating vestibular injuries are the key to healing 20% of your patients. That's every single class in the last 12, 15 years. 20% of practitioners have vestibular injuries that they didn't know about until I do that part of the lecture. That's pretty fun. And then we get Dave Burke. And I'm trying to figure out a way to get Catholi here, so I'll keep working on that. And then Jesse Turney in primary lateral sclerosis, Lyme, mold, and highly sensitive patients. and then 2 published papers. And then the Ruth Johnston Award goes to somebody that nobody expects it to go to.
Ooh.
It's always a surprise, even to the person who's getting it. And then
that's mine in the back there. That red.
That's yours. Yes.
It's a very special one.
It's the Ruth Johnson, and you got the LEAP as well.
I do.
And we have 3 certified practitioners that have completed all the steps.
Fantastic.
And if anybody is on the certification track and you're almost done and you just have 3 more little case reports to write up, if you write them up, I can put you all on the schedule because you're all coming on stage and getting your certificates in front of everybody.
But
it is. It's a lot of work and they deserve recognition. So we make a big deal of it. And then they get to come to the reception upstairs along with the faculty and the instructors and anybody that's published a paper. And then Sunday, Massey Reynolds and Kim Pittis. And the title, I don't have written down. It's PRP and...
I think we're going to call it Orthobiologics because I believe it's more than just PRP. It's any kind of... It'll be PRP, PPP, PLP, stem cell.
Okay, stem cells is the one that I was leaving off. And you emailed me the title and somehow I didn't put it on there. And
I think it's going to be Orthobiologics and FSM's role in...
That's
what we call it. That's what you call it, orthobiologics. It's injectable stuff in orthopedic medicine. Yeah.
And how to make it work better.
How to make it work better because they can't take anti-inflammatories.
Yeah.
And there can be a lot of pain after this type of injection. And when the pain relief can come instantaneously, and I've got video of him doing an injection and seconds later we have FSM running. Pretty much they're doing the injection with the sticky pads already in place. So all I have to do is press go as soon as...
You're not running 40. What are you running?
So that's like the magic recipe that I've played around with because you have to think about the mechanism of action. You can't run 40. The orthobiologic is the creation of inflammation. So our role is to support that as much as possible. So what you're running really depends on what stage of healing they are in. How much pain do they have going into this procedure? Are they in the absence of pain and it's just to quote unquote tighten something up? So our FSM post PRP prescription is actually quite diverse depending on when the injection is taking place. It's not as easy as just run 81 or just run 124. 124 is a bit of a given because something is clearly torn and broken for them to do PRP.
Yeah.
So to support that repair and healing process, obviously we're going to use a ton of 124, but like I said, depending on where they are at, depends on what else you're going to support it. Our post-operative FSM, this will all be in my talk. I don't want to get...
I know, it's like this is previews of coming attractions, folks.
Yeah, but the sneak peek is that it's not just a post-PRP recipe. You, as the practitioner, you really have to troubleshoot what stage of healing they're in. And then the monkey wrench, and again, not to give too much away, but a lot of our post-operative protocols that we have in the mode bank, we have to pull out the 40s because there's a lot of orthobiologics taking place during ACL reconstruction, a meniscal repair. So when you are giving somebody a custom care after, let's say, ACL, you have to ask the questions, are they also doing orthobiologics during your surgery? Oh, yes, Kim, they are. They're actually going to do PRP when they repair it. Okay, thank you. And then you make your modifications. So I can't wait for this talk because we're going to get the best of the best talking about PRP has changed so much in the last 10 years. So to get it right from Dr. Reynolds, who is an orthopedic surgeon, to get it right from his mouth, who's doing it day to day in a sports therapy practice, I think we're so lucky.
And everybody will be prepared to take copious notes along because we don't obviously print out the slides anymore. We send people a link to slides that they can take notes on. But there are tablets at the table, or you can bring notes, and I'll be taking notes.
And he not only is a brilliant surgeon, but he's a wonderful speaker. Like he's just so great. So
I'm excited.
Make sure everybody's booking their flights for after that.
And we'll wait, because
no, that's right. And then
after you two is 90 minutes of Jay Shaw.
Yes.
And then finishing up, holding her own, is Jen Sosnowski talking about sleep and sleep apnea and all the things. So that's...
If you're not sleeping, it doesn't matter what we're doing in the clinic, out of the clinic, what you're eating, what you're... nothing.
No.
So it's just, what a week.
Yeah. No, I'm excited. I hesitate to say we should do a 4-day advance every year and maybe do that instead of the symposium, but
the symposium is great because we get to hear
more case reports,
people who are in the trenches with it. And it was funny. I was planning out 2026 a little bit and so excited about doing more teaching and the FSM rehab course, and it's almost done. And with that comes cutting back on my practice. And so I was having the conversation as my lease is up in 2 months. Do I just stop practicing? And it's such a rock and a hard place because I really love doing both. And I think I'm going to have to just keep practicing, even if it's 1 or 2 days a week, for a couple of reasons. Number one, I love it. I love being able to help people. And there are people I can't imagine not being part of their world. And two, my practice really feeds my ability to teach this because I can see what I'm talking about every day. I'm walking the walk, I'm talking the talk, and I can say clinically, this is why it works because I'm treating this.
And it's how you learn what you didn't know last week.
Yeah, exactly.
Because this week you're doing something different than you did last week.
Yeah.
Because the patient is different.
Yeah.
And I've got 2 practitioners shadowing me this week heading into the 2-day practicum weekend.
Okay.
And yesterday, Monday, we had 2 new patients, and both of them was a 2-hour history, 1-hour treatment. The patient yesterday was a repeat patient, but I haven't seen him for 7 years. So it was pretty much like a new patient. He's incredibly complex. And the medical physician had to leave, but the acupuncturist was there. This was a chronically ill patient. And 7 years ago, I couldn't do a physical exam because he wouldn't allow himself to be touched. He couldn't sit up. The variety of his complaints were like this. Now he's older, and it was a 3-hour history. And he said, "Are you going to treat?" I said, "No. I have this switch in my head that goes off in 15 minutes at 6:45. My brain shuts off, and you're going to see it." And they kept talking, and at 6:45, it's like, somebody just pulls the shades down, and my brain just goes click. But it was like a master class in history taking.
Right.
And what he said at the end, because they tend to scattershot all of it, and for various reasons. But in the end, what he said was, "You're the only one who's ever taken the time to put all the pieces together."
Right.
And separate them out and then put them together in a story that makes sense.
Right.
And then deal with the emotional and psychological part of it. And I looked at him and I said, "You've been a professional sick person for pretty much 37 years.
Yeah.
And now you get to decide.
Right.
Do you want to change who you are? Because that actually has to come first."
Yeah.
So think about that between now and Thursday when I see you. You have to create the stable state from inside. What you have doesn't scare me. You've had it since in utero. It happened before you were born.
Right.
And then this happened and that happened. And so we followed anyway. So it's like a masterclass in history taking. And I don't know how to do that, teach that in a class without doing it.
And I think like those of us who have been in practice for a while, and especially those of us who've been using FSM for a while, know how our patient history forms have evolved throughout the years, because you don't know what to ask until you come across that in a patient and you think, shoot, I wish I knew that 6 months ago. I wish they would have started with that story. I wish I would have asked a follow-up, because you hear a snippet of their lives and then it's up to you to keep asking about the questions. And you said something really important. It is taking the history, but it is also taking that person's emotions and how they feel about the illness, the incident, the accident. Because when we talked about it the last podcast about the pain, and then how much is this irritating you? How much do you mind the pain? It's very different, right? Somebody does not walk in with a 9 out of 10 pain who had driven themselves to the appointment after being at work all day and then has to go pick up the kids. That's not a 9 out of 10. That's maybe a 3, but a 9 out of 10 irritation, or
it bothers you.
It bothers you that much, right? So that part that you're talking about is who are, and you have a slide somewhere about who are you if this pain is gone, or who would be. And I had a new patient last week, and the question that she was very used to seeing a lot of people, and her responses were almost recited. Like you could tell she has been talking about her history for a long time. She's seen
telling the story.
Yeah, she knows the story down pat. And then I said, what are one of the first things you're going to do when you're out of pain? And she's like, I don't know. I'm like, let's talk about it. What are some of the things that you've missed? What's one thing that you can't wait to do when this pain is gone? What does that look like for you? Think about it. You don't have to answer me right now.
That's so cool.
But you can see in their face the difference between a very stressful, probably traumatic history and the stress, really reliving some of the memories or the trauma or whatever. And then you can change it in a second to, when this is gone, what does your life look like? And it's okay for you to be confused by that image, because you maybe have lost hope. Maybe you were told X, Y, and Z is not possible again. So I like to have those conversations. And I would have never asked that without the very complicated, complex patients. I would have never dared to maybe go there.
And that's exactly it. And the only reason we can ask that question is that, for example, nerve pain is the easiest thing we treat.
Right.
So somebody with sciatica or somebody with a C2 neuritis who's had a migraine for 3 years every day, it's like nobody has a migraine every day for 3 years. Right. And she looks at you and she said, they told me I have a migraine, but the migraine medication doesn't work. And I said, yeah, that's because you don't have a migraine. So you use the pokey wheel on the back of her head and it's ow, ow. And then all you have to do is that. And then it's gone. And there's a little extra to do, but then it's 40 and 89.
Yeah.
It's how do you get the ability to manipulate the midbrain it's just really amazing.
I've got 3 follow-ups to what we were just talking about really quick before we go any further. When we're talking about the history and going back to taking into consideration the emotional state people are in, the frustration that people are in. And one of the things that I think a lot of us hear is nothing changes, right? They've seen so many practitioners and they're like, it's always the same. It goes away and it comes back. Nothing ever changes. Nothing ever makes a dent in it. And when you can make a dent in something, and I'm going to get struck by lightning by saying it, but sciatica, which is again, a syndrome that somebody had slapped on it. It's not true inflammation of the sciatic nerve from outer space. There are so many components at place that can create irritation in the sciatic nerve. I think we can all agree on it. Whether you're a chiropractor that thinks an adjustment is going to cure it, or a PT that thinks exercising the external rotators is going to do it, taking that nerve pain down in 20 minutes max, and them getting off the table and being like, my hip pain is gone. I'm like, and then sometimes you will get a follow-up, but now it's in my back. I'm like, great.
That's where it started, actually. So yes.
And when you say great, and they're like, excuse me, I'm like, how long have you had sciatica for? They're 4 years. Great. Okay. And now that's gone. And you're saying you're irritated because it's in your back. But that, like you said, we're chasing the source of the pain. This is where it started. And you blew through the stop signs for so long, it decided to just settle here. So I think the reframe from you saying things like, this doesn't scare me, to making these positive projections of, when this is gone, what does your life look like? Or who are you in the absence of this condition? Daring to go to that place. And then being confident when the pain does change, that if they're freaked out, and by all means, they may well be, because if something has been constantly there and now it's not, and it's in a different place, that can be scary.
Well, and if the leg pain gets worse when they bend forward, you already know to put a custom care on disc repair from their back to their abdomen, at the same time that the one on the back, it has leads that go to the foot that treats the nerve. So you treat the disc and you treat the nerve.
Right.
And it's been there for 4 years. These are the exercises. This is your homework. Excuse me. Yeah, you have homework. You are not allowed. It's not that you can't. You can. But basically, you have a sprained ankle in your back.
Yep.
And you are not allowed to bend forward and lift anything. You can squat and use your legs to lift. You can't bend from the waist, but you can't say you can't, because that makes you feel like a wimp. So you're going to say, I'm not allowed. And
yes, gives them permission.
Yeah. And then somebody will say, what do you mean you're not allowed? I have this doctor, and she's going to be really annoyed. And then you tell the patient, yes, you have a sprained ankle in your back. And we just made it 20% better, and we got rid of the nerve pain. So part of our job, I think, is to be educators.
Yeah.
This is what caused your nerve pain, is this jelly donut, where the jelly is really inflammatory and irritates the nerves.
Yeah.
And when you bend forward, you squish the jelly out the back and it dumps on the nerve. And the poster I have in the treatment room where this young man was getting treated said, you can't wait until life isn't hard anymore before you decide to be happy. And he said, he looked at it like it was a completely new thought.
Yeah.
And he said, I want to be normal. And I said, you haven't been normal since you were in your mother's abdomen at 3 months old. That's when the injury occurred. 3 months, 6 months, in there someplace. So what you have is your normal.
Right. I have a poster that says normal is a setting on the dryer.
Oh, I like that one. Yes.
So you're normal, right? Like
it's like, how about if you say he said, what I have is awful. I said, wait a minute. I have seen awful was in my office yesterday.
Yeah.
He's in a full powered wheelchair. He has only the use of his left hand, and he's losing that. That's awful. What you have is uncomfortable.
Yeah.
It's inconvenient. You can
eat,
you can see, you can use your hands, you can brush your teeth, you can do most normal bodily functions. Oh, but I feel this and that and the others. Yes, that is inconvenient. And what you have is a management problem. And this is how we are going to manage it. And nobody had ever framed it that way before.
And this, with your background with counseling and psychology, like the reframe can change everything. And having people that come in, and you see this a lot more than I do, with a loss of hope, or that is, so your big sign that says there is hope here it's just so important. And
then the next one they say is be realistic, expect a miracle, but be patient. The impossible takes slightly longer than the difficult. So, and he said, I saw that one. I said, okay, you can take that one to the bank too.
Yeah. Yeah. I think we talked about, as a practitioner, when we're educating, we draw upon our experiences in the clinic to add these nuggets. And I really noticed that, I guess, in Ireland when I was teaching, because the class was the most attentive class I've ever taught. It was the largest class and the most attentive class, because sometimes people go off and they deviate from the practicums a little bit. They were like little soldiers. When I said, okay, everybody, time to come back and sit down, they were just there and sitting down. And I could tell stories the stories resonated, for lack of a better term, more with these clinicians, especially the ones that were in practice, and I was like that too with the core. Every story that you told, you can draw upon that and say, oh, I have a patient that's like that, or I have a family member that has X, Y, and Z. Yeah. And what I've also noticed is talking about our own personal injuries or injuries from my kids. I have a lot of people that see me in my practice because they see my stuff on Instagram or whatever, and they know I'm a runner and they are also active. And they say, I wanted to see a practitioner like you because I know you're going to tell me not to stop running. You're going to help me run. And the stories that I can tell as a runner to somebody, even though we're at a different level. So I think I have a point to this, going back to FSM, is that there are stories and situations that, for the practitioners that are listening, don't forget to draw upon your own personal. It's not just about the slides. It's not just about the science. It's not just about memorizing a list of frequencies. It's thinking about the injury, thinking about the tissue, thinking about the pathology, thinking about the trauma, thinking about the emotions.
And thinking about the person that you're treating.
Thank you. The person.
Because it's not just the knee in room 3.
No.
It's John who injured his knee, and a knee injury will mean something different. The same knee injury will mean something different to every patient who has it.
Totally.
And
and I have a slide that talks about PTSD, our PTSD program, and it's not just PTSD the way some people think of it, as something that only veterans that went on multiple tours experience. And so it is a funny slide when you figure out who says it, but it says chaos is subjective. What is normal to the spider is chaos to the fly. And it's a fly in a spider web, and it's from the Addams family. Morticia Addams said something about it. And
oh my gosh.
I thought that was just very real, right? What is trauma to one person would be a dream life to somebody else, and vice versa. So like you said, a knee injury to somebody who can take all the time off of work and has all the financial resources to rehab it is completely different than a professional athlete who this may be a career limiting or career ending injury, who has no education and nothing in saving. The intensity of that emotion with that meniscal tear needs to be treated completely different in both situations.
Yeah.
And it's not just torn and broken on the meniscus.
Yeah, no, it's that too, because
it's one of the
fix it. But what else you have to do for the person?
For the person. Yeah, exactly. we have some questions to get to. I try to put a little timer at our halfway mark so that we can get to some.
Remind me to tell you about a cisplatin, a platinum-based peripheral neuropathy. Remember, I've always said that we can't treat cisplatin?
Yeah, just kidding.
Well, I did. It's because of the acupuncturist and the medical physician who were shadowing me this week is actually the acupuncturist. She said, peripheral neuropathies are chemotherapy, and specific chemotherapy neuropathies are small fiber neuropathies. And it's like, we have a frequency for small fibers. You mean it works? She said, yeah, you can take the little eye off. And we did it.
And that was, Ben Catholi did a
thing on small fibers.
Yes.
And we don't have a frequency for platinum, but we have a frequency for metallic toxin.
Correct. Yep.
So I did metallic toxin in the small fibers, and I did the same thing I do in CRPS. So we normal, numb, and painful. So I took this indelible black marker and make a line on his hand. And then the line moved from here to there in 80 minutes. And then on his foot, it went from his ankle down to his toes. His pain was still the same when he came back the next day, but the sensory pattern was different. And it was just metallic toxin and the small fibers. And I went, the sensation is different, but the pain is the same. That means it's in the spinal cord. Right. So platinum-based chemotherapy agents affect the DNA and the axons. The spinal cord is all axons. So we ran neck to feet, 16 metallic toxin in the spinal cord. And then that took the pain down more. And then the next part of it was his sensory cortex had not heard from his fingers or his toes in a really long time. So we did increased secretions in the sensory cortex. And then I said, what is that look on your face? It doesn't hurt. Feels as if it should hurt, but it doesn't. He said, yeah, that's 40 and 89. And that was yesterday. It's okay. Questions?
Yeah, we have a few, but thank you I didn't have to remind you because now we just did it. I said, I don't have to remind you now because you just did it.
I did it. And this one's the first, I get the first one because it's easy.
You can get all of them.
The Valsalva, The Valsalva maneuver is used to increase interthecal pressure, and by a little bit, a millimeter or two, expands the dura. And we use it for scarring in the dura. So it expands if you look at the diagram of the dura in the brain, it's in compartments and there's a space in the center. And when you hold your breath and bear down, the pressure from inside goes up and expands the dura while you're running the frequency for scarring in the dura. Because when you loosen the bonds that hold the scar tissue together, once loosened, they have to move. How do you move the ones inside your head? That's why you use the Valsalva. It just moves it a millimeter or two, which is just right. And then those of you that do osteopathic craniosacral, which is much firmer, the upledger trained craniosacral people don't actually move bones. Osteopaths have you put your thumb in your mouth and take your palate and go like that, or while they're doing this or this with your eyebrows or this with your ears, they physically move the tissue. And if you're running scarring in the dura or scarring in the periosteum, that kind of manipulation in the cranium makes sense, but it starts with the Valsalva because you have to make the space. So that's what I mean. I hope that makes sense.
Makes sense.
Oh, anonymous. Yeah. Autoimmune conditions exist for any number of reasons. One of the reasons is that the vagus has as its job to turn down or suppress or control the immune system, T cells and macrophages, basically. And if your vagus is working right, they stay under control. But the vagus is turned down, never off, down by infection, stress, and trauma. Most of the time, we get people after they have an autoimmune condition. That the ship has sailed. We can turn the vagus up, turn it back on to help suppress or control. I like the word control rather than suppress.
Yeah.
Control the immune system, even if they're on biologics, because eventually the biologics stop working because the biologics are attached to specific TNF alpha or interleukin 1 or various immune cytokines. FSM helps with autoimmune. You turn on the vagus, the person is changing their lifestyle factors. So my autoimmune condition is fine until I get gluten, at which point, yeah, it's a 2 baclofen day and it's on me. And supporting the stable state, but you still have an immune system that has permanent antibodies that have decided that your eyeball, your myelin, your synovial joint, your skin, your hair follicles, your immune system has decided those structures belong to somebody else. And they have a memory. It's the memory cells, it's the B cells. They're there. What FSM helps with by turning on the vagus is preventing it from getting worse. That's my hope. And you still have to treat the peripheral tissue if it's something that's treatable. We can't put tissue back that's not there. Mm-hmm. So I have never successfully treated alopecia or areata, where you lose all your hair, your eyebrows, your eyelashes, all the hair.
Right.
Never successfully treated. I've never successfully treated the one where the melanin, that the immune system attacks the melanin in the skin. We have successfully treated, and that's one of the published papers, is scleroderma, but that's because we can successfully treat the scar tissue in the peripheral tissue. So you still have to treat the mess that the immune system has created by whatever peripheral tissue it attacks. And treating the vagus is part of how you prevent it from getting worse, or I want to say picking a different tissue, but it's really interesting. People don't get alopecia and scleroderma. They get one or the other. They don't get psoriasis and the patchy skin color, or psoriasis and rheumatoid arthritis. It seems like the autoimmune conditions go with the miasms that we describe in the advanced. And so that's, it's treating the vagus is a part of all of what you've described, anonymous attendee. Lifestyle factors, supporting the stable state, thinking through how the immune system works. Sometimes you can treat the immune system for being mentally deranged. So you run all the basics and, I don't know, 970 and 116. I don't know what that would do, but it can't hurt.
Right.
I've never thought of that, actually. Yeah. And then sometimes they call it autoimmune when they don't know what it is. Oh, it must be autoimmune. Okay, sure. Why?
And I am by far an expert on this, but there seems to be just historically more autoimmune conditions popping up on patient history forms, and people are sussing out their own labs and like doing deeper dives into blood work. And I have a great rheumatologist here in California that I think about often, who I had found some autoimmune stuff just by accident as an incidental finding doing a different lab. And I came to her completely freaked out because I had this list of all these different things that had popped up. And you have 0 symptoms. Number 1. She's like, number 2, just because something is in your blood does not mean it is ever going to activate. So you have a choice in all of this. And it was such an empowering conversation to have from a rheumatologist, because people like myself do consult with Dr. Google and now ChatGPT and AI. And the problem now with blood work is you get the blood work before the doctor has a chance to even look at it. So we get these, yes, Kevin, do not use ChatGPT or AI to write FSM protocols because it's not common. That's a whole other podcast, but so we don't use ChatGPT. We have to take into consideration things. Going back to the days where your doctor would call you if there was an issue and say, this is showing up, or they wouldn't even call you because in their opinion, it was fine. So I think when people do come into the clinic and they have self-diagnosed themselves with autoimmune because some markers have come up and they're freaking out, and yet they have not seen a rheumatologist or actually been diagnosed with things, I think it's important to say and give them a copy of Biology of Belief and talk about, just because something is showing up doesn't mean it will ever activate. And there are so many holistic changes that you can do to support it, to make sure that, to your point, you're fine unless you have something inflammatory to your body like gluten that sets off the symptoms.
And then I have to decide, do I have the cinnamon roll or do I have knee pain?
Super, super easy choice in my opinion. Especially, I have a fantastic gluten-free, dairy-free cinnamon roll recipe. I'm happy to share.
Okay. We know who to call.
Yeah. All right. Moving
Comments.
Moving on. Okay.
Frequency for small fibers was 583 or 483. Let's see if it's in the buddy.
I was just going to grab that.
Okay.
But
it's raining in San Jose.
Yes. Told you it was gloomy here. I'm only about 40 minutes from there.
Small. Yep. 483. I have the 83. Small fiber. It used to have a little eye. It probably still should have a little eye next to it, because an N of 3 is only an N of 3. So and it's a very particular kind of nerve fiber. Because even small fibers have to go to dermatomal nerves, have to go to the spinal cord, have to go to the medulla, have to go to the thalamus, have to go to the sensory cortex. So there's still that long chain.
Right.
I have a 74-year-old female friend who had a stroke a month and a half ago in Portugal. Left-sided weakness, verbal is okay. Fatigue, dizziness, oops. Meclizine, no. Reported intermittent episodes of dizziness over the last year. So she's having TAAs on and off throughout the year. Imaging has been slow because sometimes it is. No MRI yet after a month and a half? Okay, fine. We do take some things for granted here. No info on where the stroke occurred. Left-sided upper and lower extremity. She can do PT and OT with this dizziness. All I can offer is long-distance treatments, unless there's someone in Lisbon. We don't have anybody in Portugal yet. Dizziness can be, I think, a cerebellar stroke. That usually affects balance, and balance affects dizziness. This is a Ben Catholi question. He is my external hard drive when it comes to neurology. It's a Ben question. So basically what you look up is either in one of the neurology textbooks, or you can ask Dr. Google, what kind of stroke causes dizziness. And then what are you going to do about it? But a month and a half after, is she paralyzed or just weak? And that suggests lower, I think, because immediately after a stroke, they get spastic. And then sometimes they get flaccid and sometimes they stay spastic forever. So just weak. Can't tell you, Sherry. I just don't have enough mileage with stroke patients. I know thalamic strokes. I know strokes are hard. The best thing you can do, honestly, is concussion in vagus or just vagal tone with increased time spent on 81 in the vagus, because yes, brainstem, it has to be down here someplace, because the vagus increases brain-derived nerve growth factor and neurotrophism. So it helps the brain recover. That's good. And so it sounds like concussion as well. And the vestibular system usually goes into the pons where the eighth nerve comes out of. The medulla is considered the brainstem, but the brainstem, depending on whose definition you use, can go up into the pons. There's a wonderful page in Netter that shows the brainstem and the pons and all the cranial nerves that come out of both of them. It's just the coolest page. You may end up seeing it on a slide someplace. Do you have any thoughts on the order in which to attack first with patients who have MCAS, who also have mold, Bartonella, Babesia, ECD, histocytosis, whatever that is? Yes, allopathic doctors are included in the patient's life, of course. Each specialist has to treat their specialty first, then deal with the others. Most doctors are out of network as well. That's a thing. So I have a question, and I should probably be asking Neil Nathan or Roger Bellica or somebody that works with testing companies. So I have a patient who brings in their testing, and they say, I have Babesia, Bartonella, and I got bit by a tick, and I have Lyme. Okay. And the question I was taught to ask was how many bands? So they do electrofluorescing testing, and it's how strong is the reaction? The question I have is, if you test 100 people who rate themselves as healthy, no symptoms, no problems, you test them all for Babesia, Bartonella, Lyme, and whatever the other one is that starts with a B. If you tested 100 people with no symptoms, how many of them would test positive to one degree or another for one of these infections? How were these tests normalized? Every test ever done, including x-rays, is you disc injuries. You do MRIs on 100 people with no back pain, and 80% of them will have disc bulges. So are disc bulges the cause of low back pain? No, because none of them have back pain and 80% of them have disc bulges. So logic says disc bulges do not necessarily cause back pain. Same thing with these. And I'm sure I'd get a lot of pushback from the Babesia, Bartonella, Lyme folks, but it's a reasonable question. Are these tests normed? Done the ELISA tests. Yep. Real-time mold. Mold is a thing. Don't get me started on that. What order? You can't fix MCAS, quiet down the macrophages, quiet down the histamine, without getting the vagus working. You can't get the vagus working as long as the patient has an infection. So you have to do two things at once, which is, given my history, I treat the mold. That's number one, it's easier. If you treat it, you usually get a good response in about 3 months. If you're treating Marcons and you're using itraconazole and the beg spray and all of the binders, for sure, the binders in appropriate doses, depending on the patient's sensitivity and the kind of mold that they test for. So you have to treat the mold in order to get the vagus working, and you have to get the vagus working to get the MCAS to settle down, and treat the MCAS with FSM, Benadryl, and no, they are not going to get dementia after being on Benadryl for 3 weeks. And what's the other thing? The liquid that you drink before you eat food, gastrochrome, for histamine reactions. I don't know who remembers, but there was a time when I was IgE allergic to everything I was eating. I had leaky gut to the extreme. So the point where steam from broccoli that was being carried by the table got on my skin, and I broke into welts every place the steam hit my skin.
Wow.
Yeah. And MCAS was not the new Candida back then. In the 80s and 90s, everything was Candida. Now everything is mold and MCAS. And somebody asked me about cell danger response, and I said cell danger response is a description of a physiologic process. It is not a disease. It is not a condition. It's how a cell behaves when it's under threat. Cromolyn, it's gastrochrome. That's cromolyn is sodium. You can inhale it. She flares with every medication or H1 or H2 blockers. Then she doesn't have MCAS. Does that make sense? If all the things you do for MCAS make her worse, there's a pretty good chance that what she has is an MCAS. One practitioner that I saw that was treating a patient for MCAS because of her genetic profile that said she couldn't handle histamine. She was highly histamine sensitive. So she had no symptoms of MCAS, but they were treating her as if she had MCAS because of her genetics. Well, you have 2 copies of the gene, one on, one off. Anyway, yeah. So if you're doing all the things you do for MCAS and it doesn't, it's 4 o'clock. Oops.
It's okay. We started a bit late because we had some bloopers and all the other things.
Michael, the primal trust. Way to go, Sylvie.
Ooh.
Yeah.
I want to circle back to where did you go? I just lost you. There you are. I was just dealing with the questions, making sure that we answered everything. I want to go back to just how the beginning started with the advanced and your laminate, or not your laminate, but your sheet with the schedule. Kevin and I were both updating both kind of websites and talking about, we have this early bird. So I know it seems crazy. March seems so far away, but if you register before, both of us, for the sports course and for the advanced before the end of the year, you save considerable money. So the early bird gets the savings, and there are lots of little bundles between all the classes that you can take, the sports course and the advanced. So I just want to, I will be continually reminding people from now until the end of the year to register early. And John Sharkey is going to be at the sports course and at the advanced. So I'm just geeking out because last year I was shocked when I was lecturing and talking. I do a pretty decent job of talking to the whole room. And then all of a sudden I see somebody sitting at the back wall on the floor, and it was Diana Cross. It's like geeking out that she snuck in a little mouse and just sat down. And
Diana Cross.
Sure, she was trying to stay awake the best that she could too. I try to make my class as animated and as action-packed as possible, but I don't even know what that time change was for her.
Oh,
there's lots of people that get to sneak into my classes.
And the nice thing about people who do register early is it lets us tell the hotel how many rooms to save.
It's nice, just selfishly trying to prepare.
It is. It really, there's a certain amount of enlightened self-interest in early bird specials because let's say I tell the hotel we're going to use 50 rooms. And so I'm going to get charged for those 50 rooms, whether we fill them or not. So I always make that reserved room block small.
Yes.
And then if by November we already have 50 people signed up, then I can tell the hotel, okay, book us another 20 and we'll see what happens.
Yeah.
And then if we fill the hotel, great, but I'm not out. Yeah. So it
helps everybody.
Works for everybody. You save money, we save money. And besides that, the advance is so much fun. It's like a big family reunion.
It really is. And joining online is great if you can't travel. And we talk about this all the time. There is just something magical that happens in those conversations that happen in the breakouts or at lunch or at night when you're sitting around one of the fires or the hot tub. People just need to come in person.
There's a thing that we do at the advanced, which is I order, last year they were too small. I try and order 2-inch agate hearts because we love our practitioners and our practitioners love FSM and love their patients. So 2-inch agate hearts, everything from rose quartz to moss agate. And they're in baskets. I used to pass them around, but now we put them out in the foyer and you can go up and pick whichever one calls to you.
Yes.
So
I have a tiger's eye in my briefcase from a couple years ago that just lives in there. And every time I put my hand in to grab a pen out, sometimes I grab it. I'm like, oh, it's my little FSM heart, I feel.
Mine's a rose quartz. Yeah.
No, of course it is. All right. That is it. Yes, Annie, start saving up. Like I said, for the end of the year, you get to save even more.
Sounds good.
Ask for it for Christmas, the Christmas present. All right. That's it for today. And we get to be here next week. So we will see you then. All right. Bye, everybody.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.